So I'm going to just wait a few minutes for people to come in. We'll get started. Okay, welcome everyone. My name is Marcy Cohen, and I'm the co-chair of the Community-Based Seniors Leadership Council in BC that works in collaboration with United Way's Active Aging Department. We represent agencies across the province providing support and health promotion and strength-based programming for seniors in communities around BC. And we're really very happy today to be having some guests from Alberta to talk about connecting people in communities for living well, transforming local care and supports to build sustainable well-being for older people with dementia. Next slide. And I'd like to begin with a land acknowledgement. So on behalf of United Way Active Aging and today's panelists from Alberta, I want to acknowledge the traditional, ancestral, and unceded territories of the First Nations of BC, on which we gratefully work and gather, and recognize as well the First Nations of Alberta that are from the territories of our panelists. So with that, I'd like to begin and just give just a few technical details about the webinar. So everyone will remain muted and cameras will be off except for the panelists. And some United Way staff who are supporting this work. So Bobby Symes, who's the assistant director and who'll be leading the question period, and Laura, who is our researcher and backup for a lot of this work. We will have a 10-minute question period near the end. You can put it in the Q&A function or in chat, and Bobby will be monitoring it and posing the questions. And also, and really importantly, the webinar will be recorded and posted, so it can be used again and shared more broadly with other people, which I really hope will happen. Next slide. So in terms of the goals and aims of this webinar, this is about a program to empower community to support individuals affected with dementia, and it's in rural communities and in Alberta. And what's one of the things that I really appreciate and unusual about the session is we have actually healthcare providers talking. So we often in the community talk about how wonderful our programming is, but here we have healthcare providers who are talking about their experience in the centrality of involving community and building community teams to really be effective in supporting people living with dementia to live well in their own communities. So just go to the next slide if I can. and introduce the presenters. So the first, Sharon Hamlin. Sharon is a registered nurse. She's got a broad range of experience of over 25 years working in healthcare in rural and urban settings as a frontline clinician and then in management positions. And she's currently a senior practice consultant with this project. Helen has a background in social work and community engagement, again in rural and urban settings. She was a frontline home care manager for 20 years and then did a number of other management and practice lead roles, and is currently a senior practice consultant with this project. And lastly is Karenn Chan, who's a family physician specializing in supporting older adults, associate professor in the Department of Medicine at U of A in Edmonton. Her research interests include working with people affected by dementia, supporting caregivers, and teaching person and family-centered care to medical learners. And next slide just gives you a bit of an outline of how we're going to organize the day or the hour correctly. So first, there's going to be short presentations from each of the panelists, and they will put up their slides, and they will be talking about the history of this project, how it got started, how it got support, what the model is, and then some examples to bring it to life. And then after that, I'm going to sort of probe deeper with the panelists to get us to talk a bit more about some of the ways that things work and don't work and where they're going in the future. And then we'll open it to questions. And then at the conclusion, we'll just have one last question for the panelists. So with that, I will get us started and turn it over to, I think it's Helen, who's going to manage the PowerPoint and the presentations for our three panelists. Thank you.
Great. Thank you, Marcy. I will just try to share my screen here. All right. Just confirm that you're able to see the opening slide.
It's just saying Sharon has started.
There we are.
Okay. I can see your nice lake. Can other people see the PowerPoint?
I can see the screensaver, I think, but the
Yeah.
PowerPoint's not there.
Sharon, we couldn't hear you.
Interesting. Okay.
Do you want me to do that, Sharon?
Well, let me just try one more time. Isn't that funny? Because we just tested this.
It's
Okay.
what life is like, particularly.
That's what life is like. All right. Let's see if this works. It says my screen share is loading.
There we
Yeah,
are.
it's up.
Yeah, we've got it.
Okay. Twice.
Thank
I just
you.
needed to do it twice.
Yeah.
Okay.
Wonderful. I'm starting off the presentation, and thank you so much, Marcy, for that introduction, as well as thank you to the United Way for inviting us to this presentation. So as we mentioned, the name of our initiative is Connecting People and Community for Living Well. And I'll get you to switch over to the next slide. So I'm going to be going over a little bit of the history first. It's still stuck on the first slide for me. I don't know, Sharon, if you can move it on to the next one.
It is on the next slide from what I'm seeing. So
Oh,
that's
is
interesting.
everyone else seeing the title slide?
I just see the title slide.
Okay,
Yeah.
Helen, let's abort my
Okay.
sharing. For whatever
Okay.
reason, it's just not coming up.
Sorry,
Isn't that
everyone,
interesting?
please be present. Is it possible for Karenn for you to just start without the slides and come up with the slides later? I think that would be a good way to go.
Oh, absolutely. Yeah, that's no problem at all. So I'm going to start it off, and when it comes up on the slide, it will be a little bit of a timeline over the past, I would say 8-9 years, where we've been working on this. So it all started around 2014 informally, 2015 more formally, where there's an initiative and a lot of kind of thought that we need to see what we can do in these communities to make geriatric care and dementia care better for those who are living with dementia as well as their carers. And it all really began with an environmental scan of geriatric services within Alberta's primary care networks and within the communities, both rural as well as urban. And it really revealed a lot of gaps in community services for people living with dementia and their carers. And so what came out of that is the beginnings of the initiative where literally what happened after that environmental scan is that a group of our colleagues actually engaged stakeholders across multiple sectors. And how they did that, they actually literally got in a car and they traveled all over Alberta and went to tons of small communities and just were there, in person to really build those relationships and make a big difference, I think, and try to understand what's been going on in different communities. And I think what they discovered is so interesting and exciting in that, some communities are quite far along in some of their initiatives and others are keen to start. And so that's kind of where it started. And they started together with these groups and everybody who is interested in stakeholders, getting them physically together in a room. They held the dementia and a conference basically on advancing dementia diagnosis and management in Alberta. And it brought people from across Alberta together into kind of one room to discuss these things and share their ideas and show other people what they're doing. And I think that it continued with that stakeholder engagement and awareness building over time. And then as that went on from that conference, they actually started formalizing goals and how to approach to bring this together into kind of one initiative. And so the focus began on looking at local capacity and how do we support these multi-sectoral approaches, because it became quite apparent that those who are doing really well actually engage more than just the healthcare system. And so it aligned with the work from the Alberta Dementia Strategy and Action Plan, and from that built the Anticipating the Future framework. And more formally between 2017 and 19, the initiative actually became named Primary Healthcare Integrated Geriatric Services Initiative, which is a mouthful. We called it FIGSI, basically, just for simplicity, but that name has also gone by the wayside for something that actually makes more sense, which is connecting people and community for living well. So initially in that FIGSI initiative, though, we had about 5 PCNs and communities beginning work locally and trying to build on the work that had happened before that and making priority areas and actions to support people living with dementia and their caregivers. And it was like a proof of concept that we could study, the change that was happening in these communities, what was really happening. And out of that, we did some economic analysis, as well as kind of proving getting some of those statistics that matters to the healthcare system in terms of continuing the work. And so we continue to build on those learnings and gathering kind of that evidence that this is an initiative that's perhaps worthwhile and worth working on. And eventually we actually were able to get a large grant from Health Canada for 1.4 million to continue our work that has been the past 3 years, which we'll talk a lot more about. And during that time, we've kind of spread and scaled the initiative provincially to more communities, as well as developed this model of connecting people and community. And really it was not necessarily that we were building the model from ground up, but we're looking back and figuring out what did we actually do like that makes this work. And so we'll be talking more about that in this presentation. And also during this past few years, we've been building a resource bundle, something that other communities can potentially take and spread and scale the work further, which we'll also talk about. So that's kind of where we are, and we'll talk about future too. But at this point, I'm going to pass it over to Helen and Sharon to continue the presentation.
Thanks, Karenn. So Helen's just going to bring up the visual of the model, which, as Karenn said, has been developed, really has been formulating itself since the early work in 2016, 2017, but was formalized over the course of the last 3 years. I think one of the most common questions that we received as a team from within the healthcare system in particular, but also with the communities, is that how is it that we do what we're doing? And so, we had the opportunity to work with our evaluation team that helped us to develop the core principles, which I'll talk about in a minute, but really it's what surrounds those core principles and what are some of those key components of advancing work at that local level to connect people in community for living well. So based on the learnings from the work that Karenn has just spoke of, we really landed on at the beginning of the Health Canada grant in 2020 to have a foundation of our work to be well-being, and what supports that, both at an individual level, but also a collective level. And we'll talk a little bit in a few minutes about collective well-being, but it's really recognizing that well-being lives within that community. Our health is supported within that community context. And so how can we have this model kind of grounded in that, as opposed to a disease focused? So the first component, which you'll see there, provincial support, is really our role as a grant team to support the local teams, but also extensions of that to other provincial groups. So we work in close partnership with Healthy Aging Alberta, and as well a number of other community and provincial organizations. But really what our role is to support them at that local level, these multi-sector community teams, to implement this model. So the model has enough kind of guidance to create that foundation, but it's flexible in terms of its ability to be adapted to that particular community that's we're working with. Part of our role also is to build the evidence. So really advancing that applied research and synthesizing that information, and then taking that information to do things like build our model and build some of the core tools that we'll talk about in just a few minutes. And as well, being an advocate. So much of this work at that local level really happens behind the scenes and appears to happen magically. But really, part of our role has been to describe that and take that information and the stories forward to a higher level, than to be able to bring awareness to that, and also then being able to leverage the resources that we can access to be a resource for those community teams. So the second part is communities advancing that local work. And the groups that we work with call themselves community collaboratives or coalitions, interagency groups. The names sometimes differ, but at its core, there's really that diverse representation from across sectors. So health sector, social sector, and community sector. And the reason that diverse representation is so foundational is that they bring with them such a deep awareness of what's happening at their local level and what some of those needs are. And ultimately, they come together with that common purpose. So in the frame of the last 3 years, it's really been around how to support those living with dementia and their carers at that community level. In the middle, then, there's our 10 core principles, which can be really used and referred to both as our grant team, but also then at that local level. So when you're running into some hiccups at that local level, how can you draw on some of these core principles to help advance that local work? And then on the right-hand side of the model are the 2 resources that have been developed over the course of the last 3 years. One is the Wellbeing Guide. And it really is a way to measure and monitor the impact of that work happening at the local level. So locally, we support the teams to go through this guide and answer the questions to be able to come up with some idea as to what their local needs are, where they're doing really well, which is also really important. And there are 3 components to it at this point. One is for those living with dementia, and the second is carers, and as well then they're collaborative. So all really in an effort to understand what is supporting that well-being at the local level. The guide itself was informed by applied research, which looked at interviews with people living with dementia, interviews with carers, and focus groups then of the community collaborative members to understand what supports their well-being, and then synthesized into this guide. The 5th component then is the competency framework, which really has articulated the skills and knowledge that are needed to support this type of work, so multi-sector work at that local level. It serves to offer some insight into the specific skills that are needed then to work together, and as well then can identify some learning needs that might be present in the community or within the community collaborative themselves. Next slide, Helen. Okay, so these are the just a snapshot of the Wellbeing Guide and Competency Framework. We have the opportunity to work with a group who helped us create the Wellbeing Guide into a fillable PDF. So after the Wellbeing Guide is completed, we're able to download the information in that can then show at a snapshot kind of where those priorities were. We work with the team in the early days to get what we call a pre-implementation rating. So that's where they identify some of those key priorities. And then after they've implemented those as a way to come back and see whether or not they've had that impact, we do a post-implementation rating. So at the local level, it's a way for them to be able to kind of demonstrate where they've had some successes and what they've been working on. And at a provincial level, as we gather information over the course of time, it will also then flag what communities aren't able to move the dial on. So what are some of those kind of structural or system barriers that are potentially standing in the way? The competency framework, there's 3 kind of main sections there: working with others, service to others, and ideas and problem solving. So we've had this developed and socialized it over the last 3 years. Part of the next 3 years will be to really be intentional about using this as a resource for those community teams and starting to understand more of the common kind of learning needs that are happening locally.
Great, thanks, Sharon. And I'll just talk a little bit about what we saw in the communities after the 3 years of work. And really what, it's one model, but what we saw was 5 approaches. It looked different within each of the communities. Overall, the communities implemented actually over 60 activities, which we were hoping for kind of 1 per community. So it really had great benefits for the people living with dementia and their carers there. So in Westlock, they really wanted to raise the profile of the work. And so they formed their Westlock Compassionate Communities. And within that group, they really embraced that lived experience and the voice of that. So at every meeting, they started to check in on how people are going. They have a number of caregivers who are part of it. And sometimes people living with dementia, if they're able to come with their caregiver there. They also really embraced looking at intergenerational activities, putting together some education across the generations and that. In Drumheller, they were really keen on trying to reach the most isolated within their community, and that had become very apparent during the pandemic. And so they set up kind of a stepping stone approach where they would have individuals developing relationships with those who they knew were very isolated, move them into very small group activities, maybe 2 or 3 people. And then for some of those people, they were able to move into their community day program, which was a program that they have set up themselves as a community to do that. In the Three Hills and Kneehill County, they actually have 5 communities that are part of it. When we joined with them, they'd done some work, but they had gotten down to very few members on that team. And so one of their focuses, which came out of that collaborative section of the Wellbeing Guide, was they knew that they needed to grow that team. And so they tapped into existing groups, they did some education and did that individual relationship building. And they now have 16 volunteers who are very active in implementing those programs and are now actually driving what are the next priorities for those communities. In Stony Plain, they also had some work, had a group that was meeting already, but they recognized that they didn't have those with lived experience. And again, that came out of the Wellbeing Guide, and so have been successful in recruiting 2 caregivers onto that collaborative. The other thing that came out of the guide is the need for carers and people living with dementia to have a safe space to kind of express their emotions, talk about the journey that they are on. And so in their individual activities, so things like walking programs, art programs, that kind of thing, they made sure that the staff and volunteers were trained so that every space could be a safe space for those conversations with it. And then the other thing they really focused on was to build their sustainability from the very beginning. So how do they weave this work into their ongoing work? And then finally in Innisfail, they were unique in actually forming a nonprofit society called Community Partners in Action. And that really raised the profile of the work that they were doing within Innisfail, but also gave them the ability to apply for grants as a group instead of one of the organizations having to hold the money from those grants, as well as they've been able to accept donations to their work as well. They had a great growth in their virtual programming, especially starting over the pandemic, and they still have what's called Let's Connect, and they still have about 250 to 300 people join every week for their programs. They have one or two things going on every day that people can join into. The other thing that they found is that there was a bit of a reluctance to re-engage in some of the in-person programming, as well as for recruiting volunteers for that. And so they've gone with a pop-up model of their programming. And so they'll hold something for 3 to 4 weeks and see if people are interested, and then maybe we'll try to develop it into something longer if there's been a really good response. So they've had golfing for all, they've had some gardening programs. All of the communities have done public education to raise the awareness within their groups also. Back to you, Marcy.
Oh, that's pretty wonderful. Thank you. Wonderful start. So just to dig in a little more, so I want to talk about your role and what you're doing to actually build that capacity. How does it look different than what you usually do, and how do you actually do it? Any one of you can start.
Sure. I mean, I think, the key is relationships are key in all aspects of this work. And so it's recognizing where we have existing relationships, who we need to reach out to build those. The communities that participated in were either ones that we knew about or that we had connections from other people. And so did that building of relationships. The other thing is us to really recognize that there's work already happening within those communities. So we didn't need to assume that, okay, we need to come in and build something totally new, but to really dig into what is happening there and how can we build on and increase capacity with what was already happening there. So kind of, take a lower key in terms of healthcare approach to it, to be able to build those relationships, but also to build on that expertise that's existing there. Anything else from Karenn or Sharon?
I would say like it being kind of involved quite early in the initiative. A lot of it was actually just even getting people in the same room to build kind of that social capital, I call it, where like people recognize you and they're like, oh yeah, and they meet each other. And I think that's really what helped us, I think, continue this work over the long term, is that we already had relationships built with people and continue to build even more relationships. But even within their own communities, right, where there's, I always remember when I went to some of these events where like the local doctor would be like meeting the pharmacist for the first time. Oh my gosh, I talked to the phone almost every day, but I didn't actually ever meet you in person before. And these are, small rural kind of places. And it's kind of like, oh, that's eye-opening. I can't believe you don't actually know each other. And it's actually, surprising how many people don't know each other.
Okay, anyone want to add anything else? Okay, maybe we can go.
I was just going to add one thing that I think helps with kind of building those new relationships is that we do hold a monthly partners meeting. So folks who may not be directly involved with us, they have an ability to come to those, receive information, ask us questions there. And so then in the future, if they are hoping for, to have some more involvement, we've already started that relationship building.
I think if I can just take a moment, Marcy, to add about the developmental component to it. I think often what we find in working with communities is that they're accustomed to the healthcare system or those from healthcare coming in and telling them what they should be doing in their community. And I think the way that we have flipped that is that we understand they know a lot about what's happening in their community anyway. And so how do we leverage that and then support them in doing what they see as important? So it's been a developmental project right from the very beginning, which can be messy in that there's a lot of new things that are being developed. Building the plane while you fly, it is one of the terms that comes up often. But I think what's so important in that is that what's being built is grounded in what is going to be useful for those community teams to best support the needs of their local population.
Thank you. That's wonderful. So I did also hear you say that there were some places where people were doing self-evaluation and they didn't manage to turn the dial or to move things forward. And so I just wondered if you could dig a little more into some of the barriers that you saw or limitations in certain places, and how you're addressing them and how that's unfolding over time.
I'll take a stab
Sure.
at the first one here. So I think one of the biggest barriers that comes forward in this type of work is those doing the work at that community level. It's actually only part of what they do. So they talk about doing this work off the side of their desks. Because many of them hold a professional role or a role within an organization or local business that is most of their time. And they do this because they are passionate about supporting their community, number one, but also because of what they do, they see that need. So having the time, having support from their respective organization or leader to participate in this type of work, and then having that time carved out to do it. Many of them, many of the teams are, you see grant funding as a reality of what's happening locally. So one of the barriers in that grant funding kind of reality is that there is momentum for a period of time and then it stops. So sometimes you get that dedicated resource to support that work going forward, but then it stops after a period of time. So I think as a number one barrier, it would be having that time to be able to dedicate to the work. And I'll turn it to Karenn and Helen for others.
I think, closely related to that is kind of policy that I guess we call it the flavor of the day policy. So whatever kind of the government is wanting to see results in, then people often have to couch what they're doing in those terms, and that takes energy that they could otherwise devote to actually getting things implemented and that kind of part of it. So I think that's another factor. The other thing, and it's part of what we tried to address within there, is their capacity to do evaluation. And so we've really tried to do a lot of support with that, because that's hard for them to find that extra time as they're implementing things to be able to really show the results and tell the story. So that's been something that we've really increased over the last 3 years of the support that we've given with that.
Karenn, do you want to add anything?
Yeah, no, I think there's always lots of challenges. And one of the things that we've come to realize too is the communities need someone outside the community to help advocate for them. And that's what the provincial team brings forward. And I think that's one of the things that is important as well in this model, is that there needs to be someone outside the community helping connect the communities to each other, but also to help advocate outside of that and look at it at kind of bigger forums as well.
Thanks. That a lot of what you're saying resonates with our experience here. Absolutely. I mean, very, very useful. So let's talk a bit more about the evaluation processes and particularly the social return on investment, your more recent principle-based evaluation. I think we'd all be interested in learning more about both of those.
Sure. Maybe
Okay.
I'll start. I'll start with that. So it's became really clear and important to us to understand that actually you need more than one way of evaluating things, that you really can't tell the story at the individual, community, provincial, and system-wide level with one form of evaluation. And so we actually have the principle-based evaluation. We had case studies for each of the communities. We had a return on investment done, which was for healthcare, and then the social return on investment, which looked at all sectors. Then we had the information from the wellbeing guide, the pre and post ratings, as well as then doing a little bit of number crunching around things like how many activities they had put together, the number of participants and things like that. So some evidence of impact. The principle-based evaluation has been really rich for us to learn about what went well and what did we need to do some work on and build on for the approach that we took in our developmental process over the last 3 years? So how much information to share, what kind of support did the teams need, those kinds of things with it. In terms of the social return on investment, we believe that this is actually the first one for Alberta Health Services, looking at it as a way of evaluating. And what it showed is that for every dollar invested, that there is a $6.49 return on value to various parts who have participated. So the value to individuals and carers equaled the value to the health and social and community sectors within the model there. And so it's great to be able to show that to leaders across, municipal leaders, provincial leaders, healthcare leaders, social sector leaders, to say, when you're doing this work, you're actually improving the value for all of those different groups. And it's fairly unusual to have a number that actually talks about those systems and those individuals. But that's, of course, the importance is to make sure that we're impacting people's individual lives also. Anything else, Sharon?
I was attempting to bring up the our slides on it, but I got kicked out of the meeting. So something is happening when I try to share my slides, because I don't think they ever came up, did they?
No.
No, they didn't. No.
Okay.
It's
Yeah.
okay, though.
I think the suite of evaluation, as we've called it, has been so important in that recognizing there isn't just one thing that's happening, it's many, many things. So, at first it was, a challenge to prove A, and then it became, well, prove B, and then it became something else. And so instead of trying to kind of reach for that next carrot or challenge in terms of demonstrating impact, it was a bit of an epiphany in that, it's actually all of these things that are important. And so, as Helen spoke of that social return on investment, it's of value not only I think to our own healthcare leadership, but within other sectors. And we've heard from the community teams how that being part of that social return on investment analysis is helpful for them then to be able to put into grant applications, et cetera, to be able to demonstrate the impact there. So, I think it's a really comprehensive way of, this is a complex, when we're supporting people across sectors through their life course, it isn't just one way. So it's a nice addition to have the social return on investment, which shows the value for individuals who it's attempting to support and systems then as well.
I'm going to just interrupt because I saw one of the questions, which was scaling this up more generally. And I know in terms of the social return on investment, there was a big difference between the analysis of the cities versus the rural areas, much more social return on investment for rural. And so I'm just preempting the questions and just asking you that, and is that too complicated a question to ask in an hour or in 5 few minutes? Because it is a big question, but I wanted to at least raise it.
Yeah, so that actually was our return on investment. And so that looked at the value to healthcare only. That was done 2 years ago, 3 years ago, I guess. Yes,
Longer.
2019,
2020.
Yeah. And so it actually makes a lot of sense to us because, one of the communities participating was kind of a mid-size city. That was the urban one at that time, and they have more resources already existing within their communities. And so the rural communities we go into often have no direct supports for people living with dementia or care. So they don't have a support group, they don't have a memory cafe, they don't have a day program, that kind of thing. So by actually participating and coming together and doing this work, they create services. And so we would expect then that would have an impact on not having to use the healthcare services as much with that. So the social return on investment was with the last communities that were involved the last 5 years. And so those were all rural communities.
Okay. So the last question here, and fairly quickly, is what next? So just maybe just one speaker sort of saying what you're planning to do over the next 3 years and why the value of scaling this up.
Mm-hmm.
Which one of you wants to do it?
Hand it over to
Sharon?
Sharon there. Yeah.
Sure. So yeah, thanks, Marcy. I think one of the questions had been, is there applicability to populations other than those with dementia? And we certainly see that as an opportunity. So in the next 3 years, and just at the beginning of April, we began, again, a grant-funded piece of work through the Health Canada policy arm there to do kind of 5 key things. One is a spread, which is spreading it to other rural communities. So taking the model that was developed and putting it into other rural communities. The second part of that is scale. And so really looking at taking this model, completing some applied research activity around an underserved population that has been identified in that community, and then tailoring the well-being guide to reflect what supports well-being of that particular underserved population, and then doing that similar kind of process to understand how this model applies to that. And then the third part of it is sustaining. So how can we take the work that's happening in those communities that we've worked with over the last 3 years, offer some support to them, but start to tease out more specifically then over the long term, because by the end of the next 3 years, we will have been working with some of those teams for closer to 8 or 9 years. So what is needed to support these communities to be able to be sustainable? One of the fourth key things then around evaluation and social return on investment. So the social return on investment that Helen spoke of has been a forecast social return on investment, which is more of a kind of predictive part. And over the next 3 years, we'll do an evaluative return on investment. So understand that kind of more deeply. And then the next key component really is around policy and infrastructure. So we know that there are certain critical factors that are necessary at that local level. And how can the policies that exist or the infrastructure that exists at more of that system level either support or get in the way of advancing that local work? So the well-being guide being used to kind of demonstrate some of those things, as you mentioned, Marcy, that they can't affect change in. But then looking at some policy recommendations and leveraging our partnership with the Health Canada group that's supporting us to do this, in what kind of policy recommendations can there be? And also, what are some of those infrastructure things? So when we think of grant funding and the realities of that, short grant terms, and the impact that can have locally, kind of making some recommendations then as to what is needed. So those are the kind of 5 key things that will happen over the next 3 years.
Okay, I have many more questions, but I'm going to stop now and open it up to others. And Bobby, if you could curate that, and then if we have any gaps, we can add some other questions.
Absolutely. Thanks, everyone. What a great presentation. Really enjoyed it. I have one question from Brenda Fowler, who asks, do you see this approach model being applicable to not only dementia care, but to well-being for seniors as a whole?
Yes.
Yeah. Go ahead, Helen.
Definitely. Yeah, definitely. And we've actually seen some of the communities that we're working with already start to do that. You know, they're often doing things about brain health. And so that's a broader audience than just folks living with dementia. But that is one of our components of our next 3 years, is to specifically look at who are the other underserved populations within those local communities, and help adjust that well-being guide based on some research to then do the whole process with those other groups. So, and we expect seniors in rural and remote communities to be one of those underserved populations that we'll find out about. Mm-hmm. Yeah.
I think we just to add to that, I think one of the things that we do is take our lead from the community team. Mm-hmm. So they're the ones doing that work on the ground. And what we did here over the course of the last 3 years is that well-being concept and the discussions that they were having as a result of the well-being guide and that work was that it was applicable in other areas of work that they were doing locally. So in hearing that, it kind of fueled our guess that the model would be have utility in other populations as well.
Great, thank you both. Just drawing attention that there was an ask about a guide for this model, and Karenn has provided a link so you can access that guide as well as other resources, and that's located in the chat. Another question that comes from participants: were there any findings on the impacts of the model on the retention or satisfaction of healthcare professionals?
Yes.
I love that question. I love that question.
You want to go,
Go ahead,
Karenn?
Karenn.
Yeah.
I'll let you answer it, but we weren't specifically looking at that. I'll tell you that as part of our research. But I think that what we found is that the healthcare professionals and everyone else actually who worked on the community initiatives within these coalitions or collaboratives, they found a lot more satisfaction, I think, in being able to have that feeling that they're actually able to do more because of that connection with each other and working together. But, you know, we didn't formally really measure that per se, but I'll let Helen and Sharon add anything else to it, but it wasn't necessarily one of our focuses.
Yeah, I think one of the big things that came out is that there are parts of the healthcare system that are very hard to engage with. So there was healthcare representation on there, often from the what we call primary care networks, which are the family physicians offices and some of their staff that are part of that. But some of the direct service providers, like around home care and things like that, it was really hard to have them involved. Some of the communities did, but many of them were not able to kind of have that engagement. So it's something that we're doing. It's one of the areas of advocacy actually that we work on in terms of trying to talk to leaders within the healthcare system, saying we don't have to be the experts in telling people what to do, because I think that's one of the crunches, is that healthcare professionals are used to, okay, here's the way you do it and implement it this way. And our role is very much a facilitating role, and a healthcare professional would be one person at that collaborative table, bringing what knowledge they have, but that knowledge is as important as the community knowledge, as the person with lived experience knowledge and that kind of thing. So it's ongoing for us work in the next 3 years around it, and I'm sure will show up in some of our policy work too.
Did you want to comment, Marcy, or should I?
No, thanks.
Great. Another question: are there specific program components that are cornerstone to having the model work?
I wouldn't say program components. The components that we have found have been really key. I think two jump out at me right away. One is around that collective well-being of that team. So really completing that part of the well-being guide so they can look at how are they functioning, are there areas of need, what other education do they need, or are they doing it really well and don't lose that strength that they've got there. And really closely related to that is how did they have the voice of people with lived experience. So people living with dementia and carers feeding into all of their discussions and their decisions that they're making. So it's not really programming per se, but it is the way that the programming gets driven and decisions get made is by having those two parts of it going. Anything else, Sharon or Karenn?
Yeah, I think that's like one of the things that I've really learned over the years is that you can't be making for someone else. Like they need to be involved, like the lived experience needs to be at the table. And I think that is a cornerstone that is shockingly often forgotten in all of healthcare or any new initiative is like, well, we have to do this and we're going to make things better, but we're not going to involve any of the people who actually are living this or, doing it. And it's, sometimes quite extreme when you think about it and how it doesn't make any sense. So I would say that's one of the biggest cornerstones that needs to be there.
I think the other thing that comes to mind is we see this work actually, and over the next 3 years we'll address more of it. But it's really that kind of micro at the ground, at the person level, the meso at the community and system level, and then that macro of the policy, right? So it really is crossing territory of all of those. And, what's interesting is that we talked about the community teams being kind of jumping from grant to grant, but that is a reality for our team on the screen today as well, in that operationally there isn't support to sustain this work. So, and a commitment really. So one of the, Karenn and Helen and I just had an opportunity to present at a conference where there were representation internationally from healthcare sector and social sector, and it was around integration. And how do we support people through their life course over those health and sector. And one of the key learnings really from it was that globally, there is not budget dollars allocated to support this type of work. So when we think of a specific component at that bigger system level, really, if we're going to see sustainable success in supporting people over their life course, we need to commit operational dollars to it. And I think that was one of the clearest messages that came through. So you can have great work happening in spurts, but if you want to see a long-term effect, there needs to be commitment, not just from healthcare, but other partners, similar to what's happening in those local communities. If we could see that multiple sectors, multiple organizations coming together at a system policy level, there would be some opportunity then to have something sustainable.
Thanks, everyone. And one more question that's currently posted, and encouraging others to continue to post questions. We have a few more minutes. But, Helen, you mentioned well-being. And so one of the questions is, do all the communities use that same definition of community well-being?
Yeah, so for our project, we do have a definition that we've built it on. It's from the McGregor Wellbeing Framework, and it has 3 overlapping components of material, relational, and subjective well-being. So the material, and it really encompasses those social determinants of health. And the material well-being has to do with, food and clothing, those substantive things. Do you have enough of to get through your everyday relationships? Do you have the relationships that help you to be involved in the way that you want, meet those socially emotional needs? And subjective, do you feel like you've got a good quality of life and you're able to do the things that you wanted to do there? So that is the definition that it's based upon.
Lovely, thanks, Helen. Marcy, no other questions currently posted, so I'll pass it back to you.
Okay, so where should I start? So one of the things that I would be interested in looking at a little more is, are you just going to stay with rural communities? Are you going to move more into urban communities? Where are you thinking about in terms of all that? And have you had conversations and dialogues with building those kind of coalitions and collaborations in larger centers?
Well, at this point, go ahead, Sharon, you go ahead.
Yeah, I think at this point, Marcy, the next 3 years for sure is focused on those rural communities. And as Helen said earlier, really the reason that that's a focus is that often there are less resources. We have other colleagues within Alberta Health Services that are doing some work with urban centers, and it's a very different kind of flavor there. And because there are so many more resources and so many more stakeholders, it becomes a bit different to try and implement that in an urban center. But I think in the short term, the focus will be on rural communities for that very reason of just having fewer resources generally.
So that makes sense. Definitely, because I think we're seeing more and more we have to think about working with rural differently and building differently. And so then thinking about that and knowing that you have support from Health Canada as well as Alberta Health, and thinking about rural communities across the country probably having more things in common than different in comparison to urban, how do you see building that kind of scaling up, and how can we think about connecting in some of our rural health networks and rural interest in this work?
I think that's a great question, Marcy, and it's something that we're already thinking about as well as we continue to kind of just make our work known and talk to other people about it. It's quite apparent that actually there's quite a need to almost like we were at the conference we were just at recently, somebody from Australia approached us because like you need to collaborate with us because we need to actually tell people how to work with, rural communities. How do you make this work? And I think that there's just so much need. And again, like I think the rural is actually very much neglected. And I think that we also been talking to some people who have interest within Canada from other provinces who are interested in the model. And that's kind of next steps, right? Like we're joking, not joking when, we say it's probably like a 20-year project. Like if we could make it keep going, then that will be the time frame where we're maybe able to achieve most of these thoughts and answer a lot of these questions. But we're right now working every 3 years right now based on granting. So I think that's hopefully that answers your question a bit about like why rural, and that it is, the intention is to spread this, Marcy, in the future. And we won't be doing it ourselves, but we'll be collaborating with others who want to also take it forward. But we're building really that evidence and how to in terms of how to share that.
Wonderful. And somebody has a speaker on, or someone else in the background, so I'm not sure who that is because it was reverberating while you were talking, Karenn.
I would
so
just
okay,
Marcy,
sorry. Yes.
Yeah, I was just going to add to that. And, in terms of the model with the provincial support, in the grant, of course, it was us and we're from the healthcare system, but we truly believe in this model that provincial support can be from really any other kind of sector. And that's one of the reasons that we're working closely with Healthy Aging Alberta, because we see potential there. Maybe there's other communities that they would be able to work with. It's having that facilitation advocacy kind of role at that provincial level. And that's where I see it really being able to go into other provinces and that. So who at that provincial level is interested in doing this type of work, and us connecting with them and sharing our learnings.
That's great. And we should think about that at United Way for sure. Mm-hmm. That's good to hear. That's somebody asked for the McGregor reference for the definition of well-being. If you could put that in the chat. And then I'm just going to shift to one last concluding question where I'm just going to ask you all to just give us a little sense about what you're learning yourselves in terms of what you think it means about how health professionals need to think differently about their role and the health system be organized. So like your personal learnings and where you see this going in terms of how to think about what health professions breaking down those limitations that you talked about in the health system based on your own experiences. Just quick concluding comments from each of you. I have a big question.
It is a big question.
Very big question.
My mind is worrying, Marcy. I think for me, I have a background as a registered nurse and have worked in acute care settings and home care and management. And I think this opportunity has created a different perspective, helped me create a different perspective in the role that healthcare and healthcare professionals play in supporting health and well-being. So we can oftentimes think of, oh, I'm a nurse working in a hospital and I will support you while you're here, but after you've gone from the hospital, it's up to you. But we need to be able to set individuals up for success. And that means collaborating and understanding what's happening within the context of where the patient or the individual is living, not only when they are in occupying a space in an acute care setting or when we're seeing them as a home care. So I think that's the biggest learning, is just shifting that perspective that we do have a role, and how do we then understand what supports the individual and then facilitate the conversations in that regard.
Yeah, and I would have to say, just for myself as working as a social worker within home care, I think I did a lot of this work on that individual, family to family, person to person basis in terms of connecting to resources and trying to build that more holistic kind of approach that, for people to live the best lives that they could within their own homes. And so now I'm taking that learning again to this kind of community and then policy level with it. It is always over and over and over again is we come from the healthcare system, we have a lot of power. People are expecting directives from us. And so we have to really turn that on our head and say, you're the experts, tell me what's going on, and we'll see. And how can I contribute? Because I think that's one of our other learnings, is that the healthcare system is great at referring out to lots of things, but how are you an active participant in taking in that knowledge and providing some of your resources to make that even better for people?
I'll just say from my point of view, I think that it's that standpoint where healthcare needs to lead, and sometimes as a physician as well, it's like that's been drilled through me, like you have to lead this. I'm like, no, I don't. And I think that that's a big thing to change in terms of mindset, like to not feel that, like, you know, because everything works better when you work with other people to build it together, particularly people with lived experience, which I think is something that, you know, is huge learnings, that things work so much better when you actually involve people who have experience with this, like, you know, in whatever format and in every way. They should be involved, from research to the developments of the ideas, and going forward and assessing even how your idea or your initiative is going. It should be involved.
Thank you. Thank you. That's great. We are just at the end of time. That was really a wonderful hour, well spent. And I'm hoping that we'll keep a relationship between you and the work that we're doing in BC and across Canada. And I hope that the people who participated here will use this webinar and share it with others, and use it as a building block. This isn't the end, it's only the beginning. Thank you.
Yeah, thanks for the opportunity. And I think our contact information will be sent out as well with meeting materials. So we welcome questions or setting up time for people to pick our brains about our experience. We welcome that.
Great. People are slowly going off. I don't know if we wanted to offer to stay on for a couple more minutes. Bobby, do you have anything? Do you want to stay on for a few minutes?
Absolutely. If anybody wants to, if they have a couple of questions, that they have the panelists or Marcy or myself, we'll be here just for another, 4 or 5 minutes or so as people sign off.
Great questions coming through from the audience. Yeah.
Yeah, I think the Wellbeing Guide is a really helpful tool that could be used very much more broadly.
Yeah.
Yeah. And I really, really like your competency framework around working with others. That's also very useful, I think, very generally useful.
Mm-hmm.
Yeah.
And just confirming that those materials are okay to post to CORE with a copy of this recording.
Yeah, they're all on our website. So yeah,
We'll make sure those links are shared.
Yeah, great. Thanks, Bobby.
Free for use, and yeah, definitely when building these, we did involve, the communities and all the people with lived experience. Like, that was one of the things that came very apparent from the first initial phase, right? Is that all the evaluation and things that came out of it, they're like, these are useless to us. Like, what am I supposed to do with this ER visit numbers and, inpatient like stay times? Like, they're like, this doesn't really make any sense to us as a community. We can't use this, but it's what healthcare wanted. And so definitely this past 3 years, it's been like, what's going to be useful for the communities to actually use, making things that are actually useful to them.
Yeah.
Mm-hmm. And part of that is for the community teams then to validate the work that they're doing, because it's done off the side of their desks. It appears to be natural, but it gives them something tangible that they can say, look, this is what this team has achieved over the past couple of years. These are the things that we've had as priorities. This is what we've been successful in. Here's how many people we have been able to connect with in this community to support in a different way. So it gives them something tangible that they can take to their own respective leaders to validate their time that they're spending with collaborative work.
We just have one question that popped in just while we're still here. Just a question, Jennifer. She asks how this project originated. Was it a direction from management or from a specific person or group?
So it was, again, quite kind of a community development approach to it, where there was a recognition of that, the the proportion of the population who's going to be over 65 is growing, and with that, then the number of people living with dementia is also growing at the same time. So province-wide, Alberta wanting to look at how do we make sure we've got the supports in place for those people living with dementia. And as Karenn had described, there was a survey done for family physicians to see what kind of supports were in place for them, and some communities had, lots of communities didn't have, and then the roadshow with colleagues of ours who went around and visited I don't know how many individual communities to hear from them. A lot.
Mhm.
Yeah, at
and
least
so,
like 14 or 15 from what I heard about the roadshow.
yeah, and part of what happened too is that there was workshops held to kind of increase an understanding about dementia, but what people were saying is, yeah, we can give people a diagnosis, and then what? They're in their communities and doing the same thing. And so it was like, oh, so we need to see how do we actually get those supports, programming, that kind of thing happening within those rural communities. So it really grew out of what the communities themselves were saying, right? Because it's like, yeah, fine, give me a diagnosis, but there wasn't anything else to go on to from there. So, which I
think it's
actually
like
think is
mixture.
across, it's improved, but within urban settings, you see that too. It's not the same kind of support network as you see like from cancer or something like that. So,
But
And I
I
think
think like
Jennifer.
oh, sorry, go ahead.
No,
Karen.
go ahead, Karenn.
Yeah, I was just going to say, because like even though there's like a general like initiative and like people wanting to make change, it really did require a lot of kind of like I think drive from a handful of people. And I'm thinking Charlene, I'm thinking Duncan Robertson, right? And I'm thinking Karen Horsley, and Dennis Cleaver, right? Like they were the drivers and passionate, and you needed that core of very passionate people involved in this pushing the management, because like the general will was there, but you need the people who push it forward.
Mhm.
So I would argue you definitely needed that little group of really, really passionate people that began this.
yeah.
And part
good
of what
point.
helped it in the early days was a commitment by government, by Alberta Health, to invest in what at the time was not yet released, Alberta Dementia Strategy and Action Plan. But as that was being developed to be released, there were some recommendations in there that the government saw an opportunity to be proactive in funding community-based initiatives to support those living with dementia. And so this early work, Karenn talked about the FIGSI part, the early work was funded by the Alberta Health to, in a way, to be proactive about those recommendations that were coming out. And I think, as Helen said, then as we learned through that first demonstration work, it was about more than just that kind of clinic medical side. It was about community side, which led to this last grant with wellbeing and funded through Health Canada. So I think originally, certainly that support from Alberta Health with the Dementia Strategy and Action Plan is what got it. And it was because of, as Karenn said, that group of passionate people that was like, okay, we need to get going on this.
Excellent. I mean, we have still some participants staying in, so hopefully those are going to be people who would take initiatives coming out of that. But we probably should say goodbye now. I'm sure everybody has busy days. Thank you so much. Yeah, this was really great. Wonderful.
Thanks for the invitation, Marcy.
Yeah, thanks again.
Nice to meet you.
Thank you.
Bye.
Okay, bye-bye.